So it is my distinct pleasure to introduce our next speaker. She is Elisabeth Rosenthal. She's currently the Kaiser editor-in-chief for Kaiser Health News. She spent many years as a correspondent with the New York Times. Currently, she's going to be speaking with us today about a book that she wrote called An American Sickness: How Healthcare Became Big Business and How You Can Take It Back. For those of you who have the opportunity to read it, it is a very stimulating, if not a little bit, tiny bit depressing book, but it is fantastic. I loved it. I hope you do too. She has a degree from Stanford University as well as Harvard Medical School. So with that, please help me welcome Elisabeth Rosenthal to the stage. Thank you.
Whoops. Hi, everyone. I would normally be shaking hands, but as you'll hear, I have a cold, and my training in medical school taught me you don't do that. So anyway, pardon any coughing fits in the middle of this talk, but and there's my clicker. I hope this is it. We'll see. Oh, there's one. Okay. So anyway, thank you all for wanting to hear about this book. It's not always directly relevant to what you do in Medicaid, but I think it's relevant to everything that's happening and has happened in American medicine for the last 25 years. So I'd like to start off by telling you a little bit how I came to write this book, which is my first and probably my last, because I discovered that writing a book is really, really hard work, especially about something that's kind of depressing, but you feel a passion inside that you have to say it. So my history, as you heard, I went to medical school. I trained in internal medicine and then was practicing in an emergency room in New York City at what is now New York Cornell Weill Presbyterian with consolidation. You know how it goes, which is another thing we're going to talk about. And I was writing a lot on the side, on a freelance basis. And then there was something called the Clinton health reform that came along. And I was working in an emergency room. So people like me who, at the time had pretty good insurance were okay in the medical system in the early 90s. I mean, my premiums were paid by my employer. The copays and deductible were pretty minimal. But the people I was seeing in the emergency room were already not okay. They were having a hard trouble accessing the care they needed. And it wasn't just, it was a system. Many of their problems were not medical problems per se. They were system problems. So I had done a lot of freelance work for the Times at that point, and when the Clinton health reform was percolating along, they said, well, do you want to come here and write about health policy? And I said, sure, yeah, sure. My assumption was that that health reform effort would go somewhere, would pass, and I would go back to being a doctor. And of course, it didn't, and I didn't, and here we are today, 25 years later, talking about many of the same issues, but I like to say the same issues on steroids. Things have only gotten worse, I think, and they have gotten worse significantly in terms of trying to make things change for people who are well insured, who do have good employer-provided insurance, because in a world of high copays, high deductibles, high prices for everything, we're very much all in this together in a way that I think we weren't in the 90s, perhaps. So anyway, I took a break from being a doctor, which turned out to be a permanent break, and took an assignment overseas. First, I was in Beijing for 6 years, covering everything and anything. Then I developed a kind of interest, and this is the great thing about being a journalist. I took another little diversion into the world of international environment coverage. And during that stay, I had an experience with a lot of different health systems overseas, some of them in Europe, and that really informed my writing of this book. Now I'm going to sound really accident-prone, but I'm a runner, and I guess I fall sometimes. So I broke a wrist in Stockholm, and the New York Times again said, well, we're going to find you a really good orthopedist. So I went to this orthopedist in Stockholm who examined my wrist, x-rayed it, casted it, and with huge apologies sent me next door to pay $400. You know, oh, we shouldn't have to do this. Next, a number of years later, I slashed open my eyebrow and needed stitches, and it was a Sunday, and I was in Rome. And I didn't really know Rome very well, so I thought, well, where should I go? And I asked friends, and they said, well, go to Gemelli Hospital. It's the Pope's hospital. And I thought, okay, I'll do that. You know, good enough for the Pope. Where they sutured my brow, 10 stitches, and again, huge apologies for charging me about 110 euros. So I had some pretty shocking experiences in terms of price. And I had heard, I was overseas for about 10 years, and I'd heard from friends in the US that things were getting really, really expensive in US healthcare. And so I kind of knew it in an abstract way, but in 2007 when I came back, I was really shocked with all the prices I was hearing. I mean, my kids, I remember when I was in training, there was this new antibiotic called Augmentin, which was really great, and it was, you know, considered expensive then, meaning then $30. But when I came back and tried to fill a prescription for one of my kids, it was over $100. Likewise, my little asthma albuterol inhaler, which I'd remembered being $10 before I went overseas, I got back. It was off patent. It was the same inhaler, except now it had a cute little dial telling me how many sprays I had left. And it, again, was close to $100, and it just didn't make any sense to me. But the main event, I guess the crowning blow for me in needing to know more about why US healthcare costs so much was I came back at 50, and I had needed that entree into middle-age screening colonoscopy, right? So not many talks start with screening colonoscopy, and probably not many books have started that way either. So anyway, but there you go. Much to the alarm of the New York Times. Well, I'll tell you about that later. So anyway, I asked the New York Times benefits people, well, how can I get this in network? And they said, oh, here's a list of hospitals that run screening clinics. And I looked down the list, and I saw a certain cancer hospital in New York that I'd partly trained at, so I knew it would do a good job. And I signed up there. But I was a little confused on the day of my test, because I went into Memorial Sloan Kettering Cancer Center, and I seemed to be being admitted to the hospital. You know, I had a wristband put on, I had my clothes taken, I had a pre-op physical. I was put on a stretcher and wheeled into what I knew to be basically a full-blown OR at Sloan Kettering. And I was a little confused about why this was all necessary, since when I was in medical school, I'd seen screening colonoscopies done in doctors' offices. But anyway, you know, a push of propofol took care of my concerns and worries, and I woke up a couple hours later with a clean bill of colon health, and all was good until I got my explanation of benefit statements, which I read because I'm a wonk about these things, and I discovered that the hospital had billed about $12,000 for my screening colonoscopy, and my insurance, you know, in these kind of chirpy letters you get, saying, good news, we bargained on your behalf, and we only paid $9,000. And of course, the important line for most patients, but not me at that point, was what you owe now was zero, right? So most patients would have thought, oh, wow, I really dodged a bullet. To me, it was an outrage, because I know that in a country where we're paying $12,000 or $9,000 for colonoscopy, we can't cover our citizens well. We can't pay for the things that everyone needs. And that kind of set me off on this crusade that culminated in this book. So as the ACA was moving through the Congress, my editor in New York, who's now the executive editor, Dean Baquet, said, well, don't you want to come back and write about healthcare reform? And I felt like, oh, God, I did that in the 90s, as probably many of you feel. I've been doing that for years. What I want to know is, why does it cost so much in this country? Because if we solve that problem, why we pay so much, we could cover everyone much better. I mean, we could buy a lot more. We're spending twice as much as most other countries. So luckily for me, he said, sure, go ahead, do a series on that. It was called Paying Till It Hurts. It was the most fabulous journalistic experience of my life. And it was partly fabulous because we decided to try something new, which was to call out to patients and say, have you had experiences with these issues, with cost issues, and with access issues? We didn't want to do like the $500,000 cancer treatment. We wanted to do each story about something that everyone could relate to. So we chose ordinary procedures. We started with colonoscopy. Now you know why. And I was about to say, much to the horror of the New York Times photo department. But they managed. They found a chart. And then we moved on to stitches, asthma inhalers, diabetes supplies, vaccinations, all the little things that everyone could say, yeah, I've been there, or I might be there, or I know people who've experienced this. That series and the call-outs on social media for patient stories produced well over 10,000, close to 20,000 comments. I tell people to read the comments because they're kind of a litany of all the ways in which our health system is failing patients. The stories are remarkable. And each person in the series is someone whose story I discovered from earlier comments. I would screen through hundreds of these things to pick out which aspect of medicine and which story would best illustrate a problem in our health system. And basically at the end of the series, we'd won some awards, you know, it had a lot of people talking. And my editor said, well, that's been a great series, now what are you going to do next? And I really didn't want to leave it, and I had still literally thousands and thousands of patient stories and things I felt I didn't understand about how did we get here? You know, as someone, my dad was a doctor, I was a doctor. How did we get to this place that literally nobody seems to like anymore? And so I set about doing this book, An American Sickness, and I learned a lot. I learned, of course, that the problems were deeper and more intertwined than I'd imagined. In doing the series, I discovered individual components of the problem, but in this book, I kind of discovered how we evolved into this crazy system that no one would have designed. And really, the takeaway I came away with in the book was that slowly over the last 25 years, financial forces and profit forces had kind of slowly made their way into almost every healthcare decision we make. And they kind of hijacked the healthcare. So this profession that I knew as a caring, healing, treating profession, and of course there's money, there's business in all of this, had become driven by the values of business, which are, you know, profit, return on investment, you know, efficiency, and basically those are not the values of medicine or healthcare, and they shouldn't be. So am I saying that there should never be profit in healthcare? That's a political decision. I have my views, but as a journalist, I'm not going to say it. But I do think we have to make sure, and that's what the book is about, that the drivers of healthcare are still caring, healing, tending to patients, and not the financial considerations. So anyway, with that being said, you know, part of what happened to me when I came back to the U.S. was I was kind of surprised that people accepted this. You know, that people were, you know, we just kind of think of high health care costs and 20% of our GDP going to health care as kind of, you know, it's endemic. It's kind of an illness that we all have to bear because we're American. And I didn't think that after being away for a long time. It was just like, wow. And I hear this over and over again from people, some of whom were in the book, who are overseas or spend time overseas who say, like, gosh, why do you Americans put up with this stuff? There's one guy who was one of my favorites in the book, who's a German guy who got in a minor bike crash in San Francisco. And he did what he would have done in Germany. He didn't think he was really badly hurt, but he wasn't quite sure. A bunch of ambulances pulled up, not called by him, called by other people. And one of them said, why don't we take you to the hospital to get things checked out? And he said, oh, okay. So he gets in the ambulance. Comes in not on a backboard or anything like that, gets driven to San Francisco General Hospital, little shaken up. The triage nurse there doing what triage nurses are supposed to do. There's a patient coming in by ambulance who's been in a bike crash, and she calls the trauma team, right? Turns out when he gets there, he doesn't need the trauma team. He gets an x-ray, is fine, walks out 3 hours later. But this poor guy, a month later, gets a bill from the hospital, not just for the ambulance, but also with a bill including a $10,000 trauma team activation fee. So, there's the problem. Everyone in the system, there are lots of good people in the system who are doing what is the right thing medically, but it turns out to be a disaster financially because someone's making money off of it, and it's not motivated by making money, but there's no incentive to control it as long as you are making money. So anyway, this book is kind of looking at how we got here and looking at how we don't have to put up with this. So I'm going to go through a little intro to the book, and I hope it stimulates some discussion afterwards. This is one of probably the most controversial piece of the book. It's a chart in the front that I made at the very end of my reporting and writing called The Economic Rules of our Dysfunctional Medical Market. Like, people like to say we have market-driven health care. And I wanted to think about, well, what are the rules if we let the market decide? And probably the most a lot of physicians and people in the healthcare system would say, like, well, no, we wouldn't do that. And of course you wouldn't. But number 2 was probably the most controversial. A lifetime of treatment is preferable to a cure. Okay, no one would say that was good medically. However, it's just true if you think of the financial drivers. And the illustration I like to use to prove this, it's one also in the book, is the story of Denise Faustman, who's a researcher at Mass General, who's looking at a treatment for type 1 diabetes that will stimulate the immune system to get those islet cells working again to produce insulin. She's had some pretty good phase 1 trials, and she went out looking for phase 2 funding. Now, who do we trust to fund diabetes research? People who manufacture stuff to treat diabetes. So she went to all of those people, and they said, and not quite in these words, gee, that's great, that's really interesting, but if your idea works, you've ruined a $20 billion industry. So why would we pursue this? And, she got turned down. No one knows if this idea will work, but she is now, and she has successfully crowdfunded $24 million for a phase 2 trial. That's the kind of thing we're up against if we trust in finance to govern our healthcare and progress in our healthcare system. The last rule, I think we can all agree, is just kind of a truism. Prices will rise to whatever the market will bear. There's very little that pushes prices down in our system. So I'm a storyteller as a journalist. I'm just going to tell you some patient stories, and you'll see how some of these rules play out on people's bodies and their lives. This is Dr. Jeffrey Kivy. He's a teacher at Stuyvesant High School in New York. He teaches chemistry and worked for Abbott Labs briefly as a researcher before he became a teacher. Excuse me. Dr. Kivy has psoriatic arthritis, so he gets infusions of Remicade every 6 weeks. Before Remicade was available about 10 years ago, he was steroid dependent. He was quite disabled. He was on crutches, had really a hard time. He could not be a teacher without this new drug, so it has been fabulous for him. Anyway, Dr. Kivy was getting his Remicade infusions at Beth Israel Hospital downtown in New York, And they were being billed to his insurer. He's a teacher, so he's great insurance in New York, at $19,000 an infusion. Then something funny happened. Not medically, you know, he'd been doing the same thing for years. His rheumatologist moved uptown to NYU Langone, and so he moved with her, and he was getting his infusions at NYU Langone. And the first infusion there was billed at $110,000. And so I said, so Dr. Kivy, you know, when he ran through the usual, like, complaining, calling NYU, calling his doctor, nothing happened, so he called me. And when I asked him, what was different? What was different about the infusion? And he said, well, I don't know, you know, there was free internet in the room, and there was TV, and there were some cookies, but no. And I checked, you know, it was the same dose, the same drug, and it really had to do with the markup that, and the facility fee that was being charged at NYU. You know, as a journalist, I called NYU and said, what's going on here? And they gave me all sorts of explanations that were kind of, to me, non-explanations that, you know, Dr. Kivy was a big guy. I pointed out that he was a big guy at Beth Israel as well. But there wasn't much of an explanation, and in the end, his insurer, and this is one of the other things I think we have to wake up to, did what my insurer did with my colonoscopy. They said, oh yeah, we were not going to pay $110,000, that's crazy. And so, but they did pay over $80,000 for each of these infusions. Now, poor Dr. Kivy, because he's my patients who I speak to are all kind of rabid about this issue. He wasn't paying for it, his copay was $0, but he was incensed by this, so he decided to switch to a different medicine that he could give himself as a shot at home. He did. It didn't work as well. He tried it for a year, and his symptoms were coming back. And he asked his insurer to go back on Medicaid, and they said, oh, no, that's too expensive. So there you go. I think patients who try to do the right thing are often caught in the middle. This is, obviously, these are not my patients. These are the Sisters of Mercy. I bring this up because I get a lot of calls from people within the health system who are really uncomfortable with the turn it's taken. I looked at Providence Medical Center because I got a call from someone named Frank McCullough, who was a pediatrician who had practiced at Providence in Portland, Oregon, his whole life. And he loved it. He was a guy with a sense of mission. He went there right out of training. At first, there were nurses, you know, sisters in the emergency room, the outpatient departments where he worked. That slowly changed. He called me 2 years ago when he retired to tell me what had happened at Providence Medical Center during his lifetime and how uncomfortable he was with it. So, as you see, it was a hospital founded by the Sisters of Mercy from Montreal in the 19th century. It served the community kind of without insurance, and then when insurance came into being, there were kind of different incentives, and then business people came in, and I saw this happen at the hospital where I trained to. Suddenly there were people with clipboards, and suddenly Dr. McCullough said the values were really being sucked out of his health system. He was getting monthly statements about how many RVUs he billed. He was getting statements about how many RVUs he billed compared to his colleagues. Then at some point, his salary was dependent, part of his salary was dependent on how many RVUs he billed. They got courses telling them how to bill for more RVUs, or you know what things they could bill more for. Whether listening to someone's lungs would help you up your billing from stage 3 to stage 4. Then they got sent to charm school to improve their Press-Ganey scores, but the thing that bothered him most, I think, was that the feel of Providence, the physical building, he said, slowly transformed from a kind of functional but, you know, not very fancy building to what he called the Providence Marriott. You know, he said there were fountains and salmon jumping around, and he said he felt embarrassed saying to poor patients who didn't have insurance or who were underinsured that he couldn't help them get their medicines, and, you know, working in the midst of this opulence. This is Providence Medical Center today. You know, it actually looks pretty basic compared to some of the hospitals I've been in, some of our medical meccas. And that doesn't mean that hospitals have to look like junior high schools, although I would say that in Europe, many of the finest hospitals do, and that's what we should be focusing on, the care, not the art. If anyone has a chance, I will send around. We did a wonderful quiz at the New York Times called "Is This a Hospital or a Hotel?" where you can just look at 10 pictures and take your guess, and I bet some of you might, you know, get more than 50%, but a lot won't. Here's one from our hospital or hotel quiz. This is Mount Sinai Hospital in New York City. Anyway, it's where we need to focus is not there. But again, to show you the kind of thing we're up against, one of the wonderful stories that I learned while I was researching the book was an old friend of mine from medical school and residency, is a general surgeon in Miami, Dr. Michael Canning. And when he was cleaning out his drawers, he found this pledge he took when he joined the American College of Surgeons in 1990. I just want to read you one line, which he pointed out to me. It says, "I will set my fees commensurate with the services rendered." Now, is there much in healthcare that sets fees commensurate with the services rendered these days? He was pretty shocked to read that, so he sent me his fellowship pledge. He's a great guy. He works at Baptist in Miami. Anyway, I, you know, being a good researcher, went to look at the current American College of Surgeons pledge, and that pesky clause was removed in 2004. So again, you know, this is what we're up against. So what kinds of things can physicians do? And again, you know, this is not so relevant to the Medicaid population, but I think it is relevant to the kind of system we're working in today. One of the patients in the book is a woman named Barbara Benion, who's in her mid-80s, and she needed cataract surgery. She lives in Connecticut. She went into the surgeon, the ophthalmologist, and he said, "Great, you need your cataracts done. We can do that." She's Medicare age, obviously, on Medicare. Medicare pays, I think, somewhere between $1,000 and $1,500 for cataracts right now, because you know, we like to try and make payment commensurate with the services rendered, and cataract surgery has come down in payment levels because it's actually much simpler than it was and much quicker than it was 25 years ago. But if you're an entrepreneurial doctor, and I'm not saying that most or many are, but some are, you can try and make up for that income, and Medicare allows this. You know, the ophthalmologist lobbied Medicare to be allowed to charge for upgrades to cataract surgery. Now, you know, it's like if you're in you know, economy class and you pay more to get, you know, to go up to the front of the plane. So what were the upgrades that Barbara Benion was offered? One was something called a toric lens, which I'm told is actually pretty useful for some patients. It's a lens that supplants the old cloudy lens, but also corrects for astigmatism. And that one was going to be an extra $1,500 for her surgery per eye. Not covered by Medicare. The second one, which is the subject of this slide, was laser surgery. You know, that sounds cool. I'm going to use a laser scalpel rather than a real scalpel. Well, all the evidence I've read and all the evidence that in the ophthalmology research is that for most patients, the laser scalpel doesn't, you know, a scalpel is a scalpel is a scalpel. Maybe there are some very rare patients for whom it's better to use a laser scalpel. But for most, a regular scalpel is fine. However, one of the upgrades that Barbara Benion was offered was the femtosecond laser at an extra charge of $2,000 per eye, right? That's, so anyway, she's lucky. Her daughter-in-law is a nurse who works in an ophthalmologist surgery center, and she asked the doctor she works for and said, yes, you should get the toric lens, but don't pay for that femtosecond laser. Now, the interesting thing about the femtosecond laser and what we're up against in this kind of realm is that when it first came out about 7 or 8 years ago, I mean, it's an expensive machine. It costs $500,000. And all the ophthalmologists said, oh, that won't work. You know, no one, practices won't be able to buy it. Only the big medical centers will invest in it because it's only really useful for rare patients. Well, guess what? If you're a business person, you can get really creative about this. So the company that makes lasers for cataract surgery now basically has portable machines, and they will let individual offices rent them out for the morning, right? And you pay for your rental by charging patients click fees, how many times you press the pedal on the laser scalpel. Now, the problem I have with this is not that it exists in the world, but when a doctor rents a laser to use in his or her practice, it comes with instructions about how to use it. Presumably they've been trained, but it also comes with a little booklet showing you how to recoup your return on investment, right? How much you have to use this baby to make back what you paid for it. And I think that's a really, really kind of toxic incentive that's gotten into our system. And again, return on investment isn't a medical value, it's a business value. Has anyone ever been prescribed Duexis? Good, I'm always glad when they're not. I heard about Duexis from a guy who's works for the city of Dallas, who's an accountant for the city. He was prescribed Duexis and was pretty upset. You know, he had some muscle pain and I can't remember, some kind of sports injury. And I was prescribed this and was surprised at how much it cost when he got to the pharmacy. So he said, can you look into this? I'd never heard of Duexis, so I looked to see what's in it. It's a combination of two now generic over-the-counter drugs, ibuprofen and famotidine. And it's a high dose of ibuprofen. It's more than the over-the-counter dose. It's 800 milligrams, which will upset your stomach. So it combines it with some Pepsid, which will calm that down. I figured out how much I could make Duexis, like a do-it-yourself Duexis kit. So, you know, I could buy what I needed, the 1-month supply of ibuprofen, the 800 milligrams for $5, a 1-month supply of famotidine for $6, so that's $11. But put it together in our healthcare system, and you get a drug that, with a free coupon, can be billed at $23.19 a month. And why is that? People say, well, no doctor would prescribe that. And this is what I say to physicians all the time. No doctor would prescribe it if they knew it was being billed at $2,319. But when the detail person comes in, or when you hear about the wonderful Duexis at a conference, the narrative is, you know, this much ibuprofen is going to upset people's stomachs. We're making it easy. We're combining it together. And here are some free samples. So give a few free samples and write the script. And the doctors never ask, how much are you charging for this? And I think that's something that has to change. Anyway, this is a successful drug. The company that makes it is doing very well selling Duexis. So someone's writing those scripts. I always like to talk a little bit about advertising. How many of you have seen these ads for non-24? Have anyone wondered what they are? This is what's great about being a journalist. You can see something like this and think, I'm going to spend a week finding out what that's about. So, you know, what is non-24 and who are these, you know, I am totally blind. I mean, it is a real disorder that affects a maximum of about 100,000 Americans who are totally blind, who have sleep-wake disorders because they don't get light cues. Because it affects a small number, and you may wonder if it affects a small number of people, why is it being advertised on late-night TV? But that's a question we'll get to in a second. Basically, because it affects a small number of people, it went through at the FDA the orphan drug process, right? So that means it didn't have to be tested on a whole lot of people. It was This is for a drug called Hetliaz, made by a small company called Vanda, which at that time had no other drugs it made. It was tested on about 60 people over about 3 months because it was an orphan drug, so it didn't need large-scale testing. And the amazing thing about when you read through the FDA hearings on Hetliaz approval is that it didn't work very well. You know, it improved sleep on the 25% worst sleep nights from about 3.5 hours to just over 4 hours, right? Not a great improvement. But at the hearing, you can see all these experts who were involved in approving the drug being really uncomfortable, saying, gee, that's not so great. But of course, what do we ask of the FDA? That our drugs be safe and effective. It was effective because half an hour more is effective, right? You're not saying it doesn't work, it just doesn't seem to work very well. The other thing that really bothered the doctors on the panel was, what is Hetliaz? It's a melatonin analog, nothing more. And so the doctor said over and over again, why don't you just tell them to take some melatonin? I mean, one of the doctors on the panel was a guy named Dr. Robert Sack, who'd actually described the sleep-wake disorder and showed in the 1990s that melatonin could correct non-24 if it was given at the right time and in the right dose. The problem, of course, is that melatonin is a naturally occurring molecule. It can't be patented, and therefore there's no business model for selling it at a very rigorously, or producing it at very rigorously dosed amounts. So hence we get the drug Hetliaz. The people on the panel who approved it were all incredibly uncomfortable, clearly. They kept saying things like, I don't know, why don't you tell them to just go buy a bottle of melatonin? You know, why don't you just say take, you know, Ambien and alarm? But, you know, the people from the pharmaceutical firm were like, you're being heartless. They flew in patients who said, you know, being blind is not my problem is non-24, and lo and behold, because it was a safe and effective drug, it was approved. And again, it cost $8,000 a month. So what's the end game for Hetliaz? It's clearly not the population of people who actually has non-24. What's the sleep-wake disorder that many of us deal with? Excuse me, it's jet lag, and they're now testing Hetliaz for jet lag. And I don't think you'll be able to charge $8,000 a month for it, but you may be able to, you know, if people are willing to pay for business class, they might be willing to pay a good price for Hetliaz too. Sorry. This is Wanda Wickeser. People like to say, oh, nobody pays those prices on hospital bills. Wanda did. She was uninsured when she had a subarachnoid bleed, and just a few days before the Affordable Care Act took effect. And she spent several years facing off with the University of Virginia Medical Center. They tried to take her house. She offered them the full amount in her retirement accounts, $100,000, which is more than Medicare or the VA would have paid for her care, and they refused. They took her to court eventually, but ended up signing a settlement with a non-disclosure agreement. Oh, good. To the rescue, thank you. This is a story. This is when you dial 911 and Wall Street answers. This article is from the New York Times, but there's actually a chapter in it on the book. In the book, one of my patients who called me was a woman who got in a minor crash in Cincinnati. Ambulance turned up, and she got in and was faced, had a broken wrist, and was faced in the end with a a $1,000 bill from the ambulance company. And she thought this has to be wrong. She works for the city of Cincinnati. She has good insurance. It was a fire department ambulance, so it had to be covered, right? It just made sense. Well, it turns out, and one thing I didn't realize is that the fire departments generally put out fires for free, but they bill for ambulance rides. And many of them, because they couldn't agree with insurers about how much an ambulance ride was worth, are now out of network. So beware of ambulance rides. She was really upset about this. She called the ambulance company, / fire department, and they said, sorry, but you have to pay up. We don't have a contract with your insurer. She said, can I have a discount? They said, no, a bill is a bill is a bill. And I think this is something that we see in a lot of parts of medicine, that as people have outsourced, hospitals, ambulance companies, physician offices have outsourced billing to billing firms. A bill is a bill is a bill. You know, the billing firms don't care if it's for your subarachnoid bleed. They don't care what Medicare would have paid. They don't care that you're calling an ambulance, that you didn't even call the ambulance. To them, a bill is a bill is a bill. And that's what this patient discovered. Of course, one of the things in Ohio is you can arrange for a payment plan. So she said, she was really pissed. She said, fine, I'll arrange for a payment plan. She's now paying $5 a month for the rest of her life for this bill. And she said it was the only thing she could do to protest, is to make it really difficult for them. Anyway, quickly now, I just want to go through some of the things that can be done. Because I think, you know, this problem is so overwhelming that every one of us at some point, including me, thinks, well, what can I do? You know, and we all kind of look to Washington and say, well, Washington is going to solve this for us. You know, I think the Affordable Care Act did a lot of really, really, really important things. As we all know, it wasn't perfect, but the coverage for people with pre-existing conditions, lifetime caps, making sure that, you know, changing the dialogue so we think of healthcare as something we should endeavor to provide to everyone. I think that those are hugely important things. It didn't solve the price problem in some ways. I think the irony of it was, you know, misbranding, because what was it called? The Affordable Care Act. It did a lot of things, but one of them was not, you know, not to make healthcare affordable, and that was always its Achilles heel. But I think a lot can be done at lower levels as we look here in Washington at the dysfunction and the lack of forward movement. I think there's a lot we can do to push the agenda, both to make it work better for individuals and also to make it work better, to apply more pressure for policy changes. This is to physicians, I always say, and I think this is in all segments of our healthcare system. What the book goes through, you know, patients, doctors, hospitals, insurers, everyone could do something differently than they do right now. And we don't, because everyone's waiting for a grand solution and waiting for the other guy to act first. And this is kind of a big ask for everyone, you know, from the top down, including patients. You know, I say to patients who say, oh, the bad guy is pharma, or the bad guy's insurers, or the bad guy's my hospital. Well, we're all complicit. You know, when patients walk in, you know, what makes me nuts is when my friends say, oh, I love that hospital, like, the art's incredible. And I'm like, no, you know. Or there's free coffee in the lobby. I'm like, no, that's not free. You know, you're a sucker. So patients have to, or, you know, when my mom goes to the doctor and says, oh, I had a really good visit with Dr. Hart, but she didn't even do an x-ray. Like, Americans expect stuff to be done. And that's, you know, patients have to change their expectations too. But anyway, physicians, I ask them to educate themselves and those around you. Open the door to discussion. I hear from patients over and over again, I'm embarrassed to talk about the costs. I feel like I can't talk about that with my doctor. I like to say cost and price are they're like the Voldemort of doctors' offices, you know. And I think doctors have to be part of this. They say, well, it'll make patients uncomfortable. I was at a conference last week, and the doctors were like, well, it'll make patients uncomfortable. And all these patients raised up and said, no, I get these bills. You know, I want to be able to talk about it. So I think we have to open the discussion. I want all physicians, and I say this to my physician, and he's been great about this, learn which centers you refer to are high cost and which are low cost. If I need an x-ray, I want my doctor to refer me to the low-cost radiologist who does a good job within his 20-block radius. He knows that, I don't, or he can know that. And I want him to say to the guy who's charging $1,000 for a wrist x-ray, I'm not referring my patients to you anymore because you're ripping them off. I want them to learn the price of the tests and drugs they order, prescribe, and complain if they're too high. Most doctors have no idea when they're checking off those boxes what they're being billed at. And many of them are not thinking very much that they're being billed or that they're being billed a lot. Because in the old days, I can tell you, most of those tests was one little red tube. You would check off the box and it would cost $6. Now it's one little red tube. It's actually gives you 7 lab values, the SMA-7. Each of those are now billed separately and for about $50. So I want doctors to know that. And I think we used to joke when I was a resident, when we ordered labs, that something was WNL, which means within normal limits when you look at the result. Some people used to joke it meant we never looked. And I think a lot of tests that are ordered, no one ever looks at, and no one ever thinks, why do we order them? And I want every doctor to ask to see the to push their hospital to show the hospital charge master. Not because transparency is the final answer, but because of several things. First of all, I think any hospital that has to show the world that it's charging $12,000 for colonoscopies would not charge that much. And B, it allows all of us who care about prices to rationalize them, to try and start pulling this price gap between what's charged and what's actually paid down. There's only one state in the U.S., I believe, that requires hospital charge masters to be public, and that's California. If you see something, say something. This is the motto in New York. But a lot of people see things in their practice or their lives or their hospital and just think, wow, that's crazy, and don't do anything about it. I want everyone to be an activist, to go to their hospital and say, why do we do that? Or if that fails, go to a journalist. I'm always open for business. Rosenthal@kff.org. And tell me something you're seeing, because that's how we know. I can tell you, now that I live in Washington, many people in Washington don't know how these things play out on the ground. I show this picture because that's Dr. Barry Lindenberg and his patient Antoinette Newell in Schenectady, New York. Antoinette Newell has been on a very, very, very old generic drug called digoxin for 2 decades. She went to the pharmacy and discovered that suddenly the price had gone up by about 1,000%. And Dr. Lindenberg got a form because the price had gone up. When the price goes up, what do insurers do? They want pre-certification, you know, and he got a form asking for pre-certification for Ms. Newell's digoxin. He faxed it back with the words, "You've got to be kidding me" on it, and called me. I looked into it. What we saw, and again, it defies all the rules of economic markets when we looked at this, is what had happened over time is that fewer and fewer companies made digoxin. We like to say that generics are cheap. I'm sure all of you in the Medicaid world have seen that some generics, like doxycycline, have gotten very expensive. There were two companies left making digoxin, and 2 companies really isn't enough to for meaningful competition in the drug world. So one of them, a company, I think it was Lanet that raised their price first, 1,000%. They got away with it, and the other said, oh, well, we could do that too. So now you have both medicines responding with this phenomena that economists call sticky pricing, which you see in the US in MS drugs and a lot of antibiotics and things like digoxin, where they're basically, as long as everyone is making good money, competition doesn't work because it's in no one's interest to start a price war. I encourage everyone to change practices. We know, and I've seen a lot of data now when writing the book. I tell people, don't send your blood test to hospital labs. Send them to Quest or LabCorp. A vitamin D test in New York State costs $16.72 at LabCorp. It costs $772 at Albany Medical Center in the hospital lab. I had a patient who was unfortunate enough to have her blood sent to Albany Medical Center. And P.S., the secondary question is why she even needed a vitamin D test. She'd had one 6 months before, probably one of those boxes that a doctor just checked for a pre-op physical, not thinking very much. I tell everyone to avoid those why don't we just tests. I've been working in an emergency room. How many times did I say, why don't we just get an x-ray? Why don't we just draw this line? You know, in a world of high-priced care, why don't we think, why are we getting these tests? How many, you know, we all know the data on surgery, arthroscopic surgery for osteoarthritis, how it doesn't work, and yet we do it all the time. Patients, doctors, why don't we listen to the things we know don't work? This is, don't trust that insurers and employers will be the cops. I think every part of the system hopes that the other part will be on guard and protect us against these prices. I now believe that this is totally untrue. You know, when people say to me, you know, oh, well, my insurer's in my corner, and certainly these letters you get promote that narrative. I think, well, you know, you don't think of your car insurer as in your corner. You know, they're just insuring your car. They're not. So anyway, you know, I think it's important to realize that insurers in this century are now almost all for-profit. Their primary responsibility is to their shareholders, and as long as they are allowed to raise premiums, deductibles, and co-payments, they're too big to care about you so long as their bottom line works out. And as we've seen, it's working out very, very well, even with some of the Medicaid programs, as in California we saw recently. When you call insurers, when I've called insurers and said, why did you write that check? You know, why did you pay $10,000 or it's $9,000 for my colonoscopy? Why did Empire pay over $100,000 for one of Jeff Kivy's infusions? This was a third person who was in one of the articles. Why did Anthem pay $117,000 for an assistant surgeon that wasn't really necessary? And the answer is, you get over and over again, is essentially, we're too big to care about you. Which is not, I would say, irresponsible, it's just the fact. You know, these were all with doctors or institutions that there were larger goals. With the third one, where it's an out-of-network physician, Anthem said, look, we don't have a contract with this guy. We don't know him. To find out whether he was or wasn't needed in the operating room, we would have to launch an investigation. We would have to get lawyers involved. We would have to take him to court. It's easier just to pay in this one case. And P.S., what they said to me is, are you going to write about this? Because then other neurosurgeons will know they could do it too, and it will work. Right? It's with some of the others. Why are my insurers paying, you know, $10,000 for a colonoscopy or Empire pay $100,000 for an infusion? They need those hospitals in the network. They are not in a really good bargaining position. If you want to sell insurance to the New York Times, you need Sloan Kettering in your network. So you are pretty much beholden to whatever they want to ask. Again, from an economic game theory point of view, everyone is doing what they're supposed to do, but it works out terribly for healthcare and for the patients. I tell people, make healthcare part of your politics, hold your hospital accountable, fight those bills. In the book, there are a bunch of templates for protest letters, so people know what to say instead of just writing the check. This is a little campaign we made up for New York. We never did anything with it. It's just an example. I would like to see insurance commissioners be far more active in ensuring that The provider directories are accurate. It is an endemic problem in almost all states. I have a cold in DC. I have a really hard time finding out who's in my network here because the directory is so inaccurate. I don't know why that's a problem. I think insurance commissioners should mandate that directories be accurate up to the day, if not the week. You know, when I buy an airline ticket online, when it shows that it's available, I don't like this in-network but not taking new patients. That means not in-network for me. And I would like to see a move to say to the industry from insurance commissioners where they have the power to do it, that when people buy insurance, they buy insurance for a year. But the networks can shift during that year. I can't tell you how many patients I've heard from who started breast cancer treatment and then midway through their treatment, the hospital and the doctor dropped out of the network. That's not okay. I think a contract should be a contract and it should be binding on both sides. Another thing I'm sure many of you are maybe have thought about, most of the hospitals in the U.S. are not-for-profit and pay very little, if anything, in the way of taxes. What do they give back to our communities? I think we should all be looking at those 990 forms and saying, is it enough? And we should want standards for what they give back to the community and make sure they're giving what the community needed. The Affordable The Affordable Care Act started to talk about that, but I have one here. But I don't think it went far enough. When people say to me, when hospitals say to me, well, you know, my local hospital says it's it's barely breaking even, and of course, in some cases that's true, I tell them, go walk into the lobby, see how much marble there is, and tell me if it looks like a struggling institution. I think we have to differentiate from those hospitals where they are really struggling to those who are investing badly and not serving their communities. And if they're not serving their communities, then let them pay taxes. You know, the narrative of, someone said to me, well, gee, you know, we don't think of Apple as a charity. You know, they give free computers to schools in a lot of states, but no one thinks that they're doing charitable work. So if you're not doing your community benefit and charity care, fine, pay taxes. Been very hard when mayors tried to go after hospitals for this, but there was one in New Jersey last year that succeeded. So I'm looking to see a bit more of that, and a bit more in the way of attempts to do so. You know, there are a whole bunch of policies which everyone in this room knows that could get us started down a better path. Reference pricing, CalPERS and Safeway in California, when they saw that there was a huge divergence of how much they were paying for hip and knee replacements, they set about finding what would be a reasonable price. They settled on something, I think it was about $40,000. And then they said to all the people in the union or their employees, you find a hospital that will do it for that or less, and we pay, but if you want to go somewhere that charges more, you're going to pay the difference. That worked really well for two reasons. It encouraged people to shop around, to ask hospitals how much they were charging and to push for prices. But the really more interesting thing it did, since these are both big purchases of health care in California, is a lot of the hospitals that were charging $110,000 for a hip or knee replacement came to these two organizations and said, oh, we can do it for $40,000, sure, no problem. So it brought the price down in hospitals that were previously high-priced providers. You know, bulk contracts for labs and radiology, longer-term insurance contracts. I want to challenge everyone, and again, this is not such a big issue in the Medicaid population, but it is because there is churn. The narrative we have in our country of, you know, every year everyone should be a consumer and go out and find something better, you know, shop for health care. You know, I think the Affordable Care Act did a lot of good things. The exchanges seem to be working pretty well this year. There's good enrollment. But the burden on patients of this churn and shopping around is huge. Shopping for insurance every year is a nightmare. And more than that, because insurers know that a lot of the people you had this year, you're not going to have next year, there's very little economic incentive, if we're trusting in that, to do the right things for chronic illness or preventive care or long-term illness. The incentive is to hope that people will go away next year who need those kind of things. Again, I would urge people, since I've seen a lot of patients caught in this trap, know how your plan works for ambulances and in other states. You know, it was great that plans covered kids up to the age of 26, but many people discovered that when their kid went to college or got a job in another state, they had little to no coverage there. And my big ask, and this is a big ask of hospitals, but it's so doable, and we would insist upon it in any other industry, is we've all heard about surprise bills. You know, when you go to an in-network hospital, the most common, and you discover that the emergency physician is out of network, or the radiology department is out of network, or the anesthesiology department is out of network, or some of the anesthesiologists are. I think, you know, a bunch of states now have surprise billing laws. New York does. That's great. You're kind of protected. But I really want the standard to be that you go to a hospital. If I go to a hospital that's in my insurance network, I feel like it's that hospital's job to ensure that everyone who touches me is in my insurance network too. And hospitals will say, well, we can't do that. Of course you can. I mean, you know which of your anesthesiologists participates in Cigna. And if you don't have any, if you participate in Cigna, it's your job to make sure you have a contract with some who do. I really want the onus taken off of patients, because I and the people I talk to are really well-informed, forceful advocates for our care, but most people can't be expected to do this. So that's my tiny big ask. I think people often don't ask enough to their employees or members, how is this plan working for you? You know, everyone grumbles a lot about, oh, I couldn't find an in-network orthopedist, and they grumble around the water cooler, but they never kind of report back to the powers that be who set up the insurance plans. I think we all have to reach out and ask. That doesn't happen often enough. I mean, every time I set foot in a hospital, I get two things, both in the same envelope. A survey asking about, you know, was the parking easy? Did I like the coffee? You know, was everyone nice? And a request for a donation, which really makes me nuts, but that's another issue. But I never get anything from my employers saying, and I've had two great employers, what's not working about the health plans we've designed for you? What would you like to be different? And I think everyone should be asking that. Again, I think the times are changing. I think a lot of the action, and this is why, you know, speaking to all of you is exciting for me. A lot of the action, I think, will be at the state level. We're seeing state-level laws now on surprise billing, on drug pricing. They're kind of tentative baby steps for the most part. You know, in New York, the surprise billing law, to enact it, you need to know that it exists. You need to fill out forms in triplicate, and then, you know, the weirdness of healthcare, you have to fax it to two different people. But it does protect you, and it's a first step. Likewise, the California drug pricing law requires the reporting of drugs that go up in price by 16% every 2 years. Again, I want to remind us all, you know, that is a great triumph that it got passed, but how unambitious we're being. If my medicines go up 16% in price every 2 years, I'm in trouble really, really quickly. So I think these kind of laws are a start, but we have to start reeling back in a system that kind of spun out of control pretty step by step. We have to reel it back in step by step too. So I hope, and my optimistic side, having moved to Washington just a year ago and watched what happened in Congress the last year, and how little we've moved is that states will lead the way on health care, much as they did on issues like gay marriage, where it became a state-by-state issue that coalesced into a national whole. And this is my last slide, my last plea to everyone. I think we just need a whole lot more transparency in the system, and I'm not one of these people who say the transparency will solve all our woes, but I think at a first step, it forces a discussion which we can't have now about how much is anything worth, because we don't know how much anything is being charged for, and we don't know what we will pay on, as individuals. So I think whether we go to a more national system or stick with some kind of market-based care, perhaps with some price corridors or national pricing, we need some transparency about what's being charged now so we can all make better decisions. Thank you, and I'm sorry for my hacking away up here into the mic.
So I have more Kleenex and more jobs right there for you.
Thank you.
Yeah. So thank you very much. So appreciative of your comments and spending time with us, even though you have clearly you have a cold. We do have some time for a few questions. We have about 10 or so minutes. So if you do have a question, please stand up, and there are mics that will be run to you. So I'm having a hard time seeing if there are any. There's one over there. So while they're running over there, I did have at least a starter question. This is a Medicaid audience, et cetera. And so as you're thinking about some of the things that we can do, from your perspective, what do you think that we as Medicaid can do to help in this, pricing and profits within the healthcare system?
Well, I think, I think experimenting with bundled care models is really helpful to show how they can work. I think, one of the things that interests me is we have been looking at it at Kaiser Health News, people who cycle in and out of Medicaid, and whether they're happier with Medicaid or crummy, high-deductible insurance. And I think, we're reaching a tipping point where Medicaid and Medicare can really show the rest of the country what they can do in the way of cost-effective care. But I feel sorry. I mean, I have gotten some calls from Medicaid directors when they realize how much they're paying for certain drugs. And I received a call from one in Pennsylvania who was shocked that doxycycline had become the #1 spend for Medicaid. I think we all have to push back where we can. And, her see something, say something was to call me, but there must be, and I don't know the ins and outs of Medicaid in the different states, but I think we really have to push for not so much rebates as transparency. We've tended to kind of see each segment of our health system as we got to protect our own, but I think we need a kind of national solution at this point.
Thank you. So there's a question out here? All right.
Hi. Earlier about putting pricing information in front of doctors at the clinical visit. And I think over the years there's been mixed research. Originally, it seemed intuitively to me, and some of the research supported that idea that doctors would change their habits if they had that information. And I think, like you said, that people think, well, that's just not what you're going to pay. And so indexing that information at the visit by benefits is a very difficult technology problem to solve. Do you have any thoughts about that, or can you see a way out of that?
Yeah, I think you know, it needs to be kind of almost Pavlovian and immediate, and in the sense of when I talk at medical schools or to residents, they want those prices on the order sheets. You know, they want the, you know, if I'm a resident at Albany Medical Center, I want a vitamin D test, $727. They want to know that, and their frustration is often, and also physicians who practice in hospital-based systems, is that they often can't get that pricing. You know, if they say, well, if I order an MRI here, what's it going to cost? Because they want to know, they know their patients are experiencing high deductibles, right? They know that this is coming out of their wallet. So they don't want to rip off their patients. But the information isn't immediate in this country ever. And it's always obscured by, oh, we'll have to check on it. It could be different for different people. I think that's, if we want to use transparency as a tool, we have to have a list, you know, there's a rack rate. Let me know what it is. And if it's really high, I'll go to someone who has a lower rack rate, because that is a starting point for discussions. And I think one of the things that's encouraging to me is that younger physicians often really want to know this stuff. They don't have this kind of Voldemort attitude. And sadly, in this age of high deductibles and high co-payments, more and more doctors are having this kind of come to Jesus moment about prices, where there's a surgeon, conservative Republican surgeon in the book, who took out some excuse me, took out a patient's appendix, and the patient came back to him and said, you know, gee, doc, thank you, I feel much better, but now I have this $10,000 bill which I can't afford. So he's now leading a kind of Medicare for all charge in his part of northern Wisconsin. So, you know, I think there's a lot of incentive to say, oh, we know this doesn't work, and I don't, you know, it's a different era now, and that gulf, which used to be small between what was billed and what was paid, has grown to this insane amount. So no one can make rational decisions, not hospital systems, not patients, not physicians, and not people in Medicaid doing purchasing either. So I think we should try it again, but really try it in a real way.
Thank you. There are other questions? Right here in the front. Run, Lucy, run. It'll come on.
I'm curious what your response is when people say, well, this is jobs, this is income, this is you know, people's income. What's your response to that?
What you mean?
When you're talking about reducing,
Right.
When we're reducing prices,
Yeah, right.
for those people who couldn't hear.
And I think this is, yeah, it's jobs, it's income. I think where I come out in the end is that this is much more an economic jobs issue than a healthcare issue right now. I mean, there are many, many towns in the U.S., many cities, Pittsburgh, Cleveland, that are pulled out of the recession on the back of healthcare jobs. Not all of them useful in the sense of contributing to patient wellness and well-being. You know, many of them in the coding and billing and you know, that kind of part of healthcare, which is, you know, we know a lot more goes to administrative costs than in any other country. And so I think that's a second reason why we have to spool this back gradually. Like, I'm not asking for us to, you know, say, okay, tomorrow we're going to be France and have 12%, or Germany and have, you know, 10% of our GDP. But we really need to kind of start turning the ship around, because it's not on a sustainable course. And, you know, for all the jobs in healthcare that contribute to the business of healthcare but not health, I think there are others that are not being done. You know, we have an aging population. We don't take care of them very well. You know, I think, could we redirect people who are doing administrative things to do more in the way of home visits, to, you know, there are lots of interesting things we could do. Have adopt, you know, a half-mile radius area that, of underserved people, and make sure they're getting health care in terms of social work and helping with services. You know, could we send people out as we do, you know, I mean, this is going to be an outrageous proposition, but, you know, similarly to the postal workers who are in every building every day, should maybe there be people who go make regular visits with people and just hang out with them? You know, loneliness is a huge problem among the elderly homebound. So I think we could be much more creative about how we do health care and how we use that to serve the purpose of health rather than business. Now, you know, that's a little utopian, I know, but I don't think it's healthy for our economy that so many cities in the U.S. depend on the industry of medicine to keep them going, and I don't have an easy answer for that. So.
Thank you so much for speaking with us today. Please join me in a round of applause. Thank you.
All right, everybody, thank you. Thank you so much, Dr. Rosenthal. You came here and talked about the American sickness while having an American sickness. I will reflect a couple of things similar to what I said yesterday morning, one of which is you've given us a lot to think about and a lot to chew on, and you certainly pulled no punches in terms of everyone who's part of a problem and part of a potential solution. But I would also reflect that, similar to what Judy has said, is that a lot of the reform that really is necessary is happening at the Medicaid level.
Yeah.
And with our plans, with our providers, with our patients, and being led by state Medicaid. You know, whether it's delivery system reform or the payment reform that's going to get us to where we need to go, we need to continue to move forward, we need to push aggressively, and to make sure that Medicare is doing that as well so that we can continue the momentum.